As you've heard, the meeting is going to be recorded. Just keep that in mind. It's great to have this meeting again. It's been a while, and I do hope you had a lovely summer. So today we have two great speakers. So as you can see on the screen, both of them are trying to basically automatize medical imaging. So on the one hand, we have Aurélien Maillot, who decided to go for a kind of the good old image processing technique, right, to make post-contrast CMR as automated as possible. And on the other hand, we have Gaël, who is looking more into the future by using AI to automatically segment lung images. So thanks so much, Gaël and Aurélien, for being with us today. If you don't mind, we're gonna start with Aurélien. So most of you know Aurélien. Aurélien has been with us for a little bit than a year now, a little bit more than a year at working at Lyric. But you spent 5 years in Switzerland, right, at the EPFL University, and you actually worked a couple of years with the CHUV, the team of Professor Stuber, and Siemens as well. So thanks so much, Aurélien, and the room is yours now.
Okay, so good morning to everyone, and I'm gonna present our work entitled Explainable User-Independent Inversion Time Selection for Fully Automated Black Blood Late Gadolinium Enhancement Cardiac Imaging. It's not published yet, and it's still a work in progress. And before talking about the implementation, we will first quickly introduce bright and black blood LGE, why TI selection is needed in the first place, and how can it be beneficial to add automation. So the goal of LGE is to perform cardiac tissue characterization, and it's used in order to do the assessment of regional scar formation and myocardial fibrosis. How it works, so we have an intravenous contrast agent, and we have two case scenarios. You don't have accumulation in gadolinium in normal myocardium, but you do have accumulation in abnormal myocardium. The effect of this accumulation will lead to a shortened rate of T1 relaxation, and this can be seen in the image by a hyper-intense signal. And in the places where you don't have this accumulation, you will have a non-enhanced signal. So this is the bright blood LGE, and one problem we might have with bright blood LGE is at the blood-pole interface, and especially for subendocardial and focal subendocardial scars, where the signal from the blood can create problems for the delineation with the scar. So to circumvent this problem, black blood LGE has been introduced in order to improve the scar visualization. And it does so by not only nulling the signal of the healthy myocardium, but also of the blood pole. So here is just an example of images where it might have been difficult to tell the presence of the scar in the bright blood LGE, but it's more apparent in the black blood LGE when the signals are nulled for the blood pole as well. So how do we obtain such images? There is different ways of performing black blood LGE. We just present one. The one we use here that is based on a T1 row prepared module that has been implemented at the Lyric by Aurélien Bustin. So we have a 100-degree inversion pulse here, and just after we will play a T1 row preparation module that is composed of 4 spin lock, 2 refocusing pulses, and a tip down, tip up rectangular pulses. And what happened is that the spin lock, it will have a different effect on the T1 row relaxation depending of the different region. So you can see in green, the infarct region, the signal from the blood in red, and from the healthy myocardium in blue. And after you apply this spin lock for a given time, which is TSL, the spin lock time, you will wait for the recovery. And you can see that depending at the time you will play the readouts, so this is the inversion time, you will have different contrasts of the image. And you want to reach the optimal inversion time where you have the best contrast when you are nulling the blood signal and the healthy myocardium, but you do have signal in the scar. So how is it done actually in practice? This is done doing a TI scout. So we have here two parameters that can influence the contrast, but the time of the spin lock, it will be fixed. So it has been optimized beforehand. So we only are left with the inversion time to choose. And this is done by doing a TI scout. So this is the acquisition of 2D images at different inversion time, going from 60 milliseconds up to 160 milliseconds with a 10 millisecond increment. So you have different contrast, and what happens is that manually you have to select the image that leads to the best contrast. For instance, here would be this 100 millisecond images, and you use this value to trigger the actual black blood reconstruction afterwards. So why is this step important? It's really important because the TI you select directly impacts the qualitative score assessment and the quantitative post-processing analysis. So this will determine the contrast of your image. And what could be the benefits of automating this process? So it will enable to standardize this LG workflow first. It will also enable to increase the exam reproducibility. It can help in accelerating the sequence parameter selection step, and in the same way, accelerating the overall LG acquisition. And finally, it will help to reduce the MR operator workload by providing a more user-friendly sequence to use. So the aim of the study is to transform the myocardial scar characterization into an effortless and accurate procedure with a straightforward clinical integration. And this is why we will go old-fashioned image processing technique, as Aurélien mentioned, because we wanted to have specific constraint for fast clinical acceptance, one of which was the simple implementation. And another one was to take advantage of explainable technique in order to help this clinical acceptance. So for the data set, we retrospectively collected 120 patients that underwent CMR for known or suspected ischemic disease at 1.5 Tesla. We have our TI codes that is consisted in 11 short axis 2D images with TIs from 60 to 160 milliseconds with an increment of 10 milliseconds, as I showed you before. And after this, we have the actual fast 2-minute free breathing motion compensated T1 row black blood acquisition. And for this data set, we perform manual annotation by 2 experienced radiologists. So they manually selected the 120 patients, and they performed this annotation twice so that we can also look at intra-observer viability. So for the technique, it works in 2 distinct steps. The first step is extracting a region of interest, and the second step consists in a pixel intensity-based selection. So for the first step, we started with our TI scout images, the 11.1, and we want to first detect a coarse region around the heart. So this is here depicted in green. We perform a first segmentation, and from this first segmentation, we want to select a sub-region that will contain information of both the blood pool and the myocardium. Once we have this segmentation, this is on this type of images that will apply our really simple algorithm, which consists in computing the one-dimensional histogram of each images, computing the envelope and detecting the maximum value. And we will look at the global maximum that is depicted by the red arrow here, and we'll use it in order to select a specific threshold, which is represented by the dashed orange line. So what we are looking is at all the pixels below this threshold, and here they're represented in red overlay on the image, and we can just count the number of these pixels and express as a function of the TI to have a little graph like this. And what we can see is the goal is just to find the maximum value of this graph, which in this case will be 90 milliseconds, and we could use it for the actual acquisition. So if we go first, explain a bit how the region of interest extraction part works. So what we could do in order to get a coarse region around the heart, we decided not to go with image processing techniques, but to take advantage of prior knowledge at the scanner during the exam. Because what happened during the exam is we need the positioning of a shim box, a 2D shim box that is centered around the heart. And we could use this prior information to have really accurate detection because this information is present. So how does it work in practice? When you are inline in the scanners, you have inline parameters that are expressed in a given coordinate system, which is called the image coordinate system. You can see it in the square A here. And you also have information that are displayed, the B panel, which are the information relative to the image, but expressed in millimeters in a reference coordinate system. So we can retrieve this information either directly in line if they are saved, or retrospectively in the DICOM and in the raw data in the Twix. And from this retrieve information, this is the panel C, we can plot, for instance, the short axis plane and what we are interested in here, for instance, the shim in green. And we have to go back to the image coordinate system. So you have a mapping between image coordinate system and the reference coordinate system. This mapping matrices M, which depend only on pixel spacing in the column and row direction. And you also have the X, which is the row direction cosine of the image orientation. So it will tell you the direction of your slice, basically, in the row and column direction. And you have the X here, which is just the value of the image position patient. So this is the position of the first pixel in your image expressed in the reference coordinate system. So we have to inverse these matrices. In practice, it's a pseudo-inverse we use. It's not necessarily invertible. And when you compute this pseudo-inverse for any given point, you can retrieve the information in 2D space, pixel space, and you can use this information in order to trigger the first segmentation. Then we start from this coarse detection thanks to the shim, which is the image A, and we want to select a subregion. We continue to keep it simple, and we just tested 2 different shapes, and we want to have information about the blood pole and the myocardium. So we just want to be within the hertz, basically. And we tested 30 different shapes, ranging from this original size to 1/4 of this original size. So for each different region of interest, we compute our automated TI. We compare it to a manual expert TI using an absolute difference. And we do this for 40 different patients of the optimization set. So with this 40, we have now a mean absolute value. So for each region of interest, we have one value, which is the mean absolute difference with respect to a manual annotation. So this is what is depicted here. So you can see the mean absolute difference for rectangular ROI and circular ROI for different ROI size. And highlighted in red are the ROIs leading to the lowest mean absolute difference, which was 2.25 plus or minus 4.18 milliseconds for both the rectangular and circular. For rectangular of size for shim divided by 2.5, and for the circular, it was the size of the shim divided by 2.2. So it's not really easily understandable what this 2.25 means. Is it good? Is it not good? Because we are talking about a discrete value with a fixed increment on 10 milliseconds. So another way to represent it is just to look at the difference for all acquisition. So this is with the best ROI, rectangular one of size for shim divided by 2.5, and for the 40 acquisition. What you can see is when it's 0, it means that the automatic algorithm selected the exact same TI as the manual expert. And when it's plus 10 or minus 10, it's selected an image that is either plus 1 or 1 before the image selected by the expert. So for 0 milliseconds, we have 31 out of 40 cases, which represents 77.5%, which we have a perfect match, and plus 10 milliseconds in 9 out of 40 cases. And it's good to see that we don't have outliers. So we don't have selection that are further away than 1 images for this validation set. So if we want to look how it looks, to see how it looks visually, so here's an example where it matches. And here is an example where the automated TI selected 1 images apart from the expert. So now we want to validate this in the 80 remaining patients we have. So we selected, we kept this region, optimal rectangular region of interest, and we want to compare it to inter-observer variability. So sometimes two observers won't choose the same TI as in this example. We want to compare it to intra-observer when the same expert performs the annotation twice. And we want to compare our algorithm, which is what we call the auto versus manual variability. So if we look at the mean absolute difference, so the same metrics we use, what we can see is the highest mean absolute difference is for the inter-observer variability, followed by the intra-observer, and then the auto versus manual variability, which means that we have a better consensus in our validation set with our automated algorithm compared to one expert than one expert compared to another, and then one expert that performed the same selection twice. Again, we can look at it in a different way by looking at the percentage of TI scouts, where at 0, it means that it selected the exact same TI. So in 76.8% of the case, the automated algorithm selected the same TI compared to an expert. And in 75% of the case, when you have the same experts performing the task twice, it will select the same. And this goes a bit down to 68% of the case for the inter-observer variability. It's nice to see that it's well contained in the -10 +10 region, also for the inter-observer and intra-observer variability, which means that we have quite a consensus in the selection of the TI. And we don't have much outlier, but we have a few cases at +2 and -2 and one at -3. And we can just have a look visually at these cases. So here at the top, you can see one with +2 images, so +2 20 millisecond images difference. And we can see that these images are really close to each other, and it's not straightforward to select. And it's the same case below here, where we have not global optimal TI selection, because at some point we have nulling of the myocardium, but not of the blood pole, for instance, at 90 milliseconds. And at the other, we have a good nulling of the blood pole, but not of the myocardium at 120 seconds. And it's nice to see that the algorithm can also depict this. So if we look at the result for the cases where it's quite close to each other, we can see that the maximum number of subpixel threshold is quite similar, like between 120 milliseconds and 100 and okay, I don't have the pointer, so I will add it. So here we have a quite similar value, which reflects that we are really close to each other. And for the next one, pointer removes the. Okay. For the next one, we can see also here, so the case where we don't have the nulling of both structure at the same time, we can see it on the overlay. So here, first we will have a good nulling of the myocardium, and it's a bit more complicated here, but we can see also that we have a good nulling of the blood pole and not so good at the nulling afterwards. We want to do an automated black blood LG, so to use this information in order to trigger the actual acquisition of the black blood. And we can already have insight on the automated black blood. So this is not fully automated, but it's just we compare manual black blood with black blood LGE that has been reconstructed with a TI that is the same as the one we selected. So it's just to have an insight. If we had run the algorithm, it would have select a TI and perform the reconstruction. This would lead to this images on the bottom, because the same TI was used as the one used by the algorithm. So the goal then is to do the inline implementation. So we are working on it. We have a C implementation that is working now, and we are currently working on the ICE implementation. But unfortunately, we don't have the prospective results yet. So it will come soon, I hope. But when we go inline, it's nice to also do a bit of quality control, because you want to go from your detection directly to the reconstruction. And if you have a problem in the middle, you will have to wait until the final reconstruction to detect it. And you have different problems you can try to detect, one of which is suboptimal TI range. So with a minimum inversion time that is either too high. So this is an example, for instance, where the selected TI would be the one at 60 milliseconds, but maybe if we had chosen 50 or a smaller one, we could have reached a better solution. And this would be nice to redo an acquisition before selecting this TI as the optimal one. And same way, we can have a maximum TI that is too low. So here it would have been nice to test it TIs that are higher than 160 to be sure that we have a global maximum. And also, it would be interesting to be able to detect the presence of artifacts and maybe give a feedback to the user if we have artifact instead of directly launching the black blood reconstruction. So for the first two cases, it was really straightforward to implement because it corresponds to the case where the algorithm will select either the first TI in the range of TI proposed. So here, what we can see, if the minimum TI is too high, the algorithm will select the TI of 60 milliseconds. We know that this is the lowest we use, so we could directly re-trigger an acquisition with a smaller inversion time. And this is the same when the maximum TI is too low. Here, we could re-trigger an acquisition with TI higher than 160 until we reach an inflection point in our function and we go down again to be sure that we have our maximum. For the presence artifact, it's a bit, it might be a bit more difficult, and especially because we didn't have much data with artifact in our data set, so we couldn't do a proper comparison for artifact detection, but would like to test it. And one easy way to do it again is to look at all the threshold value during the validation set. So we have an adaptive threshold that is based on the histogram computation, and we can retrieve all the value of this threshold for the 40 validation set and compute a mean value sorry, it was a median value, it's not the mean value. A mean value of the threshold, and this was 11. And when we can look at the percentage of high sub-threshold value and low sub-threshold value. So we use percentage because we have different size of the region of interest. So it wouldn't make much sense to look only at the number, but we look at the percentage. And if we sort the images by the percentage of sub-threshold pixels, what we can see is that when we have a really high sub-threshold percentage, we tend to have really good quality images with a good nulling of the signal. And when we look at the lowest sub-threshold percentage, we have images of lower quality, either with artifact or at the bottom row. Sorry, here's an example where we obviously had to redo the acquisition, and this would have been detected by the latest case we presented just before. Okay, so just to conclude, we think that this simple algorithm could be, again, a good candidate for automated black blood LG in clinical practice because it matches expert performance. It's really easy to implement, and it's super explainable. So it's also, we could visually see why the algorithm selected this inversion time, and the goal would be to be able to provide information inline also, if it's possible to visualize it inline. And it can also be extended to other black blood sequence. So we tested with T1 row preparation, but actually it's not restricted to this because it can be used to every sequence that use TI Scout. Future works. So the inline implementation and evaluation is obviously needed in order to see if it works properly in all cases inline as a scanner. And also, we would like to test new applications that are possible by TI automation. So this is really the first step. And here we only try to select the parameters and to mimic what the manual experts are doing. But we could expand a bit this framework and perform tasks that are not achievable at the moment. So we could just think about doing 2D scouts, for instance, with TI and Spinlock. We could try to do an adaptive T1 an adaptive TI during long acquisition. And we could also try not to have fixed increment, but to refine the increment of the TI and see it improves or not the quality at the end. So I would like to thank all the people that participate into this study, and I would like to thank you for your attention, and I'm happy to answer questions if you have any.
Thanks so much. I think it was a very nice presentation and a nice project, even though I'm biased, obviously. Do we have any questions from the audience from Bordeaux or Lausanne?
Yes, can you hear me?
Yes, Matthias.
Yes.
Okay, I have two questions. You know, your technique may have a major impact, not only on what you're doing with the techniques that Aurélien has developed in Bordeaux, but if you think about every center out there in the world who does, you know, late gadolinium enhancement with inversion recovery, not with a sophisticated solution as that of Aurélien, but with simple inversion recovery, you know, how much value could you add there? And this would kind of broaden the scope of the impact of what you have done. So what are your thoughts there? The second question is, how important is the difference to what people do nowadays? And that this relates to the first question. You know, a lot of people just take an inversion time, if it's a little bit more sophisticated, perhaps dependent on heart rate, but they're not going to eyeball the inversion time on a regular basis, right? So, so the question is what is the added value if you think about the fact that you need one extra scan and that you need some extra time in order to accomplish this?
Yeah, so for the first question, I think this relates to what we wanted to do, like, because it's so simple and to implement and to deploy, this is the goal is to apply it obviously to other technique than the T1 row mapping. And in order to answer the question for the added value, so I think that it's really also a preliminary step, and the added value will really be seen afterwards when we can add when we can perform tasks we cannot perform manually at the moment by doing the automation. So just having a quantitative value will, I think, open the door to other projects and to other selection techniques that we couldn't, or we don't have the time to do it manually. So here it might be still straightforward to do it in practice, just selecting from 11 images. But even if it's straightforward, like, it has to be done, and it impacts the images at the end. So this is really something not to be we have to take into account. If we can do it automatically, it will like enable to have more time to do other parameters. Selection, for instance, or it will also just enable to be able to quantify and to go beyond what we can do at the moment. So I'm not sure if it's clear. And in clinical practice, so this is important, and I think Aurélien is better well suited to answer this question. But it sometimes told me that you can have like a problem in the actual black blood reconstruction if these parameters are not choosing accordingly, and it seems that it does happen sometimes in practice. Correct me if I'm wrong, but
yes, and you know, from what I've seen every day at the hospital, I would say maybe 20% of the patients we will get a bad contrast on black blood LG because the MRTech is not used of this contrast. So even though for us it's easy to select the good TI, for them it's not, for some of them. And so when they select the wrong TI, we always have a bad image quality at the end of the day. So it's about 20% of our cases. So with this algorithm, we will have, I don't know, near 90% of success, hopefully.
yeah,
hopefully.
I think so.
Yeah.
Great, thank you.
Welcome.
Any other questions?
I have a question.
Is it Davide?
Yes.
Okay.
It is him.
I'm physically present. Aurélien, can you go back to the inter-observer slide, or it's not too difficult?
Yes, I can. You still see my screen, right?
No, we see something. Maybe that's a slide you made, but
Just a moment.
Maybe unshare your
Oh,
screen.
sorry.
Yeah, okay.
there you are.
This is more like a comment than a question because it's something that happens in any study that does that tries to automate stuff.
Is it here?
Yeah.
Okay.
The observation would be that probably it's fair to it's just fair if your variability is less than or equal to the intra observer and inter observer to say that your algorithm is okay. Like you cannot claim that it's better because it depends on which of the two observations you actually looked at, right?
Sure.
And you choose one that's completely random, or which of the experts you looked at.
No.
And,
okay. Yeah.
so
Go
in
for it.
case of
Sorry.
the intra, that's really, I mean, it's very close. So I guess you could say that it's very precise. So you are as good as that specific observer that you used. However, the fact that it's lower than the inter observer, it's good. It's neither good or bad, right? Because you don't know if the other observer was better than the first. Like you don't have a ground truth that is observer independent. And this is something all papers do. They say like it's were better than the inter observer, but I would say at this point it's fair to say we are good enough. We can't get better than that.
Yes, no, you're right, and I think I mentioned that it matches the like manual performance, but I'm not stated that it outperforms manual selection because we don't know the ground truth for sure. And as you mentioned, like when we compare with an expert, what we've done, so we had like it was a bit of a methodological issue, but we compare. So we didn't select like the smallest difference for the intra observer. We take randomly the automated TI and compare it to the manual annotation of one. And we do it for each annotation. So we had 4 annotation and we did it for the inter observer as well. But as you said, we never know what the ground truth is. And the only statement that we can say is that in these specific cases, if we use this automated algorithm, we'll have a difference that is similar or less than the difference between 2 observers manually that you will observe in clinical practice. So it could be nice to test it like with more observers to be sure that we don't have a bias. But again, we have quite a consensus. So it doesn't seem that one is really always select a good one, and other is far away. So because we have this consensus and it's +1 images, and the images looks really close to each other, the ones that are selected, you don't have that much difference. I think this is just a claim to say, okay, if we use it, we won't be able to tell, hopefully, if it was the automated algorithm or if it was the manual expert in this case. But we have to test it in line with more data sets. And yes, I don't know if maybe there was a better way to compare it to assess this claim. I don't know.
I mean, but this is totally fine. It's just that like your claim of you will not be able to say whether it was the automated algorithm or an expert. It means your algorithm cannot get better than that.
Yeah.
Well, I mean, and the only way to have the ground truth would have been to do two times the same scan, but then you cannot do it with this timing because they will have different timings afterwards, the black dots.
Indeed.
But that would be the only real way to see which one of the TIs was better.
And this is also the problem we have actually, because when we want to compare the impact of the selection on the actual reconstruction, let's say that like we have a 10 millisecond difference, maybe you won't be even able to see it at the actual reconstruction. But you cannot run the acquisition for the same patient exactly with 2 different TIs, as you mentioned. So it's difficult to quantify the impact of the TI selection on the final images. For instance, when you have just a 10 millisecond difference, it will be like you will have a great difference with like a 16 millisecond difference, but with 10 milliseconds, it's hard to know how much it will improve.
I mean, maybe another one thing one can do is to test like some random difference, like to figure out what's unacceptable error on the final image quality and say, yeah, we are within this. So that
Yeah.
would be a different step.
Definitely.
Okay, thanks. I will.
Hello, yeah.
Hi, Jérôme.
Yeah, hi. Very nice presentation already, and it was really clear.
Thanks.
My question is a bit related to what we discussed before, but so with your Scott images, you are not really measuring the T1 recovery, but it's more like a T1 apparent, like an effect of T1, yeah, an apparent T1 recovery. So how is it, I mean, how does that translate for the acquisition after that, for the inversion time?
Sorry, so I'm not sure to understand the question. So
It doesn't matter, Shalom, because you don't care about the real T1. You just want to have the bug null.
Yeah, but I mean, here, since you modify, I mean, the magnetization, the recovery, it won't follow the T1 recovery curve because you are
Right.
hitting it every single time to get your Scott images.
It doesn't matter.
So you're measuring an apparent T1 recovery.
You don't measure T1. The end point is to have a good contrast between scar and the rest.
Right, but because the inversion time you will follow, you will choose will be basically from the apparent T1. While when you do the black blood image, you don't excite it all the time. So the T1 recovery will be different. So
Okay.
the inversion time should be different as well.
Yeah, that's a great question.
So that's why I'm not 100% sure if this will, affect.
okay, so you sorry. Okay. So
So you
you
understand my question? So when you
Yeah,
get the Scott images, you basically you keep exciting all the time your T1 your magnetization. So the T1 magnetization is not going to magnetization is not going to follow your T1 recovery, but something we call an apparent T1. So it will be a bit slower.
yes.
So basically this is not the same. So it's not the same T1.
Okay, so and ultimately like the TI's inversion time should be like different because you don't have the same T1. That's right.
Exactly, because when you do black blood, then it follows a different T1, so it's not the same. So the inversion time will not match.
Okay.
I'm not sure to understand, Jérôme.
Well, if you do it like you do with that Scout, you invert the magnetization and then you nibble away for every image you make at every time point you do, right? So you do not let the magnetization recover freely as you would during a real scan. So therefore, it affects the inversion time, and Shalom is absolutely right. This leads to an apparent T1, right?
No.
Because you affect the inverted magnetization. Now, to solve that, the loop locker people did that with small excitations to minimize that effect.
No, I think you think about a bright blood TI. So what we do is bright blood LG, where it's a kind of a cine scout. That's not what we do. No, not at all. The sequence that we use for TI is exactly for TI selection. So the TI Scott, black blood TI Scott, is exactly the same sequence than the black blood, the final black blood LG sequence. That's why it's not an apparent T1 as you have with a Cine Scout.
So you only have one image per inversion.
Absolutely, that's a single shot acquisition. Exactly. But you're right, Jérôme, for the conventional acquisition. And that's why we have sometimes a shift in TI plus minus 20 milliseconds in depend on the center because of the apparent TI. But that's not the case here. The sequence is exactly the same.
Okay. Sorry, I missed that.
No problem. Do we have any other questions, maybe from Bordeaux?
Yeah, if not, I maybe have a dumb question.
Hi, Chris.
How long does the Scout take?
So, do you want to answer?
I don't get the question. How long was the
Scan
How
time?
long is the Scout scan?
Scout time? Is I won't say anything stupid.
So
Do
we
you
have-
remember?
We have 11 images here, right? So single shot images. So one every 2 heartbeats. It's about 20 seconds.
Okay. And so what's because you just said that they're the same sequence. So what are you getting more of in the actual scan?
So in the actual scan, we do multiple averages to get higher SNR, and we cover multiple slices of the heart, right? So that's why it's longer. Right. We have 4 averages for the the black blood sequence, so it's a bit longer to recover SNR.
Mhm.
Any other questions? No, so I think we're gonna move to the next speaker. Are you still around, Gaël? Thanks so much, Aurélien, for your
You're welcome.
presentation.
Thanks to you.
Thanks. Gaël, are you still around?
I am around.
Amazing. Hi, Gaël. Just everybody. So it's Gaël is a radiologist at Bordeaux University Hospital, and I guess some of you know Gaël because he's been working with some of you. I think Jean Delacoste, correct me if I'm wrong, from Lausanne. Was it on the UT sequence, Gaël?
Yes.
Yes. Okay. So Gaël is a expert in lung imaging. So I'm gonna say your title in French, but I'm sure you're gonna have a better translation. So you're gonna talk about quantification automatisée des altérations structurales bronchio-pulmonaires dans la mucoviscidose en TDM et IRM. Thanks so much, Gaël, and it's your turn, I guess.
So hello everyone. So thank you, Aurélien, for the invitation. Indeed, we are part of the CRCTB laboratory, which has an interest in both cardiac imaging and thoracic imaging. So my main challenge today maybe is to make my presentation attractive to you because you guys are mainly involved in cardiac imaging. But I know that in the center of Lausanne as well, you have an activity in lung imaging. So I have selected these two work that might be of interest to you, I hope. The first one is about the fully automatically segmentation of airway structural alteration by using artificial intelligence. So this is a CT study, but we hope to extend it to lung MRI application. And then I have selected this work about the quantification of T2 weighted signal MRI intensity because there is an overlap with interest in a black blood weighted sequence as well. So the first work was made in collaboration with two US universities, the Center of Cincinnati in Ohio and the Center of Kansas in Texas. And the aim of the study was to use deep learning for quantifying the structural alterations seen in CT of cystic fibrosis fully automatically. So a little bit of rationale. So cystic fibrosis, as you may know, is the most frequent genetic disease in Caucasians, and imaging is useful to follow up and assess the severity of the disease. And this is a complementary evaluation of standard pulmonary function test. And there is a very interesting new era of therapy because now there are new treatments that have emerged that are crazily effective on the disease severity, and we expect that imaging may play an increasing role in assessing the follow-up of under treatment of these patients. So what we have to do that nowadays we are basically performing visual score. And we say that this bronchi is dilated, this one is thickened, there is a consolidation here, there are mucus plugs here. But we know that these visual scores are subjective and sometimes not reproducible. For instance, we have unpublished data with Lausanne, and between Catherine Begelman and me to assess the presence of bronchiectasis, we measured an inter-observer variability of kappa equals 0. And I'm not kidding. We measured a kappa of 0 to assess the dilatation of bronchial visually. And there has been some attempts to automatize this visual score, but segmented each abnormalities over 100 and 100 of CT slices is crazy job. So what has been proposed in the literature is to divide the CT scan into grid of 2 centimeters square and then to try to perform the segmentation, but this may lead to a loss of information by using such a grid to do this. So we try to automatize the segmentation by using artificial intelligence. And for this, we had two cohorts. The first one was a classic AI work with training and test, and then to measure an overlap between the segmentation. But we also perform a clinical validation where we did not measure any overlap, but just check if clinically patient with this new treatment improve, and patient without this new treatment may be either stable or worsen over time. So we did not apply a grid. So this is a native CT scan, and we have chosen in our method to precisely segment all airway structural abnormalities, the dilatation of the airway lumen, the thickening of the airway wall, the presence of mucus plugs or small bronchiolar mucus plug in the lung periphery, or the presence of lung consolidations. There was an agreement of between three expert radiologists for this, and we also use three AI algorithm, 2D AI algorithm, Inception ResNet V2, ResNet 50, and the classic unit. And the three algorithms were combined to perform a majority vote to be able to reach an agreement between those three AI algorithms. So this is an example of what we have obtained. So these are the three images that I showed you previously, and the AI was applied over the full set. It was a 2D segmentation, but we applied it to the full set of 2D slices over a CT scan to reconstruct 3D images. So this patient had no detected abnormalities. So the volume of lesion was measured to be equal to 0. And then the AI was able to automatically detect the presence of the bronchiectasis, wall thickening, mucus plug, and then to perform a 3D reconstruction of the volume of the lesions. So the AI still missed some abnormalities. So as compared to the human segmentation, there was an underestimation of the lesions, but the concordance was very good. And here is an example in a video of a full set of CT images, so you can recognize maybe the lung structural abnormalities. And this is what AI is able to do fully automatically. So all structural abnormalities are tagged and over the full set of CT slices, so allowing to get a 3D image reconstruction of all the structural abnormalities and to know which one is it, or to calculate the total volume of the lesions. So the Dice coefficients were the mean of the total abnormalities was 0.71 as compared to human segmentation, and there was a decrease in recall of 0.63, but there was a very good precision of 0.84. The calculations correlated to clinical values. All of them were significant, so there was clinical relevance of these values. And before and after 1 year of treatment with this newly developed treatment in cystic fibrosis, so this is an example of one patient with Mill disease. This is small bronchiolar mucus plugs that may be a little bit difficult to compare over time, but AI detected them and then allow a 3D reconstruction of the volume of lesion and allowing an automated longitudinal follow-up of the disease severity over time. And you can see that the volume of lesion decreased over time in this patient. So, and the reproducibility, because this is a software-based, fully automated segmentation, the reproducibility was perfect for AI and imperfect for the human evaluation. And the AI was able to make this crazy job in about 90 seconds as compared to 2 days for a human to segment a full lung volume over 100 and 100 of CT slices per patient. And what about lung MRI? So we expect, and maybe we could be able to translate this application towards lung MRI, because as you may know, nowadays, the lung MR imaging quality has improved thanks to the advent of UTE and zero-T techniques, and maybe we could be able to translate our application towards this kind of high-resolution lung MR application. So next, the second work that might be of interest to you is a quantitative imaging of airways using T2 weighted sequence and black blood property. So I have showed you that one of innovative solutions of lung MRI is the advent of high resolution morphology, similar to CT, but we know that morphology is not all the information in the lung. Maybe, for instance, this patient, if we apply a T2 weighted second, we can see that there is an asymmetry in lung MR signal with a high T2 value in the right lung and right bronchi as compared to the left lung, indicating that there is an inflammation of the airway walls in the right, but not in the left. And this cannot be seen by using morphological information only, and we need signal intensity information. Another example of this, longitudinally, if you are under a treatment, if you look at these bronchi walls, over time, it is difficult to assess visually if there is a modification over time of these bronchi walls. But if you look at the T2 MR images, we can see there is an edema with high T2 intensity of the left-sided bronchi that totally disappear over time, and we can see that there is an obvious change in signal intensity, which is not obvious by using morphological imaging only. So there is an interest in these T2 signal intensities in the lung. I am not able to describe very precisely this imaging sequence, but basically this is a two-dimensional T2 radial sequence where we are able to fill a case space radially in 2D, but also to get several and reconstruct retrospectively several TE values from the same case space acquisition. And because we are able to reconstruct this TE value, we are able to reconstruct the corresponding images, and then to calculate with the classic equation the T2 value, and to from the same case space acquisition to reconstruct a T2 mapping of the lung. So here is an example of patient with cystic fibrosis, where we can see high T2 signal intensities contribute to an increase in water, and this is seen in inflammatory modifications such as mucus plug or airway wall thickening. And this is an example of patient without any abnormalities, and you can see that the lung is a black hole, and I like this. So I think that we can take advantage of this artifact, because there are a huge amount of susceptibility artifact into the normal lung. But I think that it is very interesting to get advantage with it, to negate the signal intensity of the normal vessels and the normal airway that are not visible. And all that we can get is a signal intensity of abnormal signal intensity value, and we can negate the normal structure thanks to the susceptibility artifact. And this is a 2D acquisition, but if we match the slice thickness to the spatial resolution of the matrix, we can get a 3D isotropic lung volume in a patient, and then to perform a 3D isotropic T2 mapping of the lung. And because this is the same K-space acquisition from the 5 T values to reconstruct the T2 mapping, there is no problem of possible mismatch in spatial location of pixels. So first, because the normal lung is black and the abnormalities have high signal intensity value, we can use simple thresholding method to extract the information about the high T2 signal intensities and then to reconstruct it in a 3D manner to get the volume of the T2 signal intensities. And we can also fuse this information to the T2 signal intensity as extracted from the T2 maps, and then to get a fused information about both the extent, the volumetric extent, and the signal intensity of the lesions over a full lung volume acquisition. And here an example of the interest to get this black blood property. This is a CT scan reconstructed in 3D. So you can see that the abnormalities are mixed with the normal structure corresponding to the normal vessels and the normal airways. But by using T2 weighted lung MRI with this black blood property, you can extract more specifically the signal intensity of the lesion only, and then to be able to segment them by using simple thresholding methods. And this is an example of patient before and after a treatment. You can see that visually these signal intensity values are decreasing dramatically over time, but you can also reconstruct it in 3D and then check that the signal intensity of the lesion also decrease along the decrease of the volume of the lesions. So this is an example of work from Lausanne about similar work with a black blood UT sequence for 3D. And this was the images were shared, and I thank Jean Delacoste and Catherine Benjamin Aubry to have shown me them. And this is a 2 3D radial acquisition, but without any contrast injection. And here, this is the first acquisition without the black blood acquisition, and the same image with the black blood acquisition. And you can see that the signal intensity of the large vessel in the mediastinum or here are lowered by using this imaging acquisition. And I think that it was interesting as well. So the physical principle is totally different, but this work was very interesting as well from you guys. So thank you for your attention. I will and this was a parallelism with maybe some work from Aurélien to try to extract automatically and make and to perform some black blood property within the cardiac image as we are trying to perform in the lung. And thank you for your attention.
Thanks so much, Gael. Fantastic talk, as usual. I can't believe you segmented manually 30,000 slices.
It took me 6 months.
Questions. No one? Yes, Davide? We cannot hear you. Sorry, guys, you have to unmute yourself. Good.
I have a question related to the treatment, not to the segmentation. But the treatment, then it's not only slowing down the progression of the disease, it's actually regressing it. Then you could even avoid the transplant, or it's just to gain time for a transplant?
So I agree that it is said in the literature that there is a possibility to make the structural abnormality regress, but I agree that in fact most of the time is it is a matter of stabilizing the disease much more than making it regress. But the article that I have pictured is about a newly developed treatment, which is a tree therapy, because nowadays it was mono or B therapy, and now there is a tree therapy. And I can say, and we are currently making a report on it, that the structural abnormalities are fantastically decreasing, such as we have never seen it before, and it is truly decreasing dramatically with this tree therapy.
I see. Also, like the patient symptomatically is better, like it corresponds to how she feels.
I'm sorry, I didn't
The question
understand.
is the symptoms, whether the symptoms decrease for the patient as well.
It corresponds to the decrease of the structures, corresponds also symptoms.
Yes, yes, of course. The patients say that they are feeling much better.
I have a question related to that. With these wonderful drugs, there are now many patients that will be coming with cystic fibrosis, who now will live into their adulthood, will have children, etc. Something that wasn't possible before, right? So this is a splendid outlook. Simultaneously, the follow-up of these patients includes serial CTs. Now, while this didn't matter so much in patients who only lived into being 13 or 14 years old, sadly, now all of a sudden it starts to matter, because these repeated CTs accumulate, they accumulate the dose, which is correlated with the risk of developing cancer. We all know that, right? So now if you could go back and replace, let's say, every other CT by an MRI, you would gain quite a bit. So where do you see that going? And also if you're thinking about low field in order to address that problem.
I fully agree that we should at least think about it. So the practice of imaging in CF are very heterogeneous in Europe, but we objectively, the very vast majority of imaging centers are still using CT with the reduction of doses. But I fully agree that this treatment will change the landscape and how we can envision the use of imaging, because to assess, it is not now just to see what happened, it is to follow up the response to treatment. And in this context, I do believe that imaging must have another role, another place, and we may have to use it more often than before. And in this context, I do believe that lung MRI, especially without any contrast enhancement, because the UT imaging allowed to get high resolution morphological images without any contrast product administration, should be accepted by the patients themselves, because there is no radiation, there is no contrast product injection, so the patients may accept it much more easily than other techniques. And for us, clinicians, I do expect to demonstrate that these techniques are also very sensitive to assess the response to treatment, and if possible, by using fully automated quantification instead of subjective visual assessments.
Thank you very much.
Do we have any other questions for Gael? No, so I think,
I don't
yeah.
know. I wanted to ask something because I was curious with the with the AI algorithm that you use for segmenting in CT, the images had a lot of colors where like each color was representing a different lesion.
Yes.
And the precision that you reported was also like within lesions, for instance, the lesions that you reported were correct as well? Or is it just precision in segmenting in general?
So all the precision for all labels were similar, that is higher than 0.80. And the decrease in the dice coefficient was related to a decrease for some labels in recall. So that is a sensitivity to detect the lesion. But once it was detected, there was no false, a very few amount of false positive detection. So when the AI missed some of them, but once it was detected, it was true positive identifications.
Okay, thank you.
And there were 5 labels in total.
Thanks, Gael. I think we're running over time. So let's thank our speakers again today. Thanks, Aurélien. Thanks, Gael, for your time. I'm gonna share the next flyer. So stay tuned, come and join us on November 19. We'll talk about cardiac MRI reconstructions, how you go from a MATLAB or Python code to the bedside. And we're gonna have Valérie Ozen talking about the good old Gadgetron, so the open source framework. And we are next gonna have Davide Piccini from Siemens, who's gonna talk about FHIR. Stay tuned. Have a nice day, guys. And thanks again, everybody.
Thank you. Have a
Thank
nice day.
you.
Bye-bye.
Goodbye.
Bye-bye.